Hello, and thank you so much for being interested in active listening tools for supporting mental health in academic spaces. My name is Wendy Ingram, and I'm the CEO and founder of Dragonfly Mental Health. And we are recording the main speaking and presentation purposes portions of our 2-hour active listening tools for supporting mental health in academia talk and workshop here so that people can utilize this on their own time as a free resource, as well as potentially use this as training for either becoming a Dragonfly ambassador or a community champion. So thank you so much for tuning in, and I hope you find this very, very helpful, as so many hundreds of academics already have. So thank you so much. So when we hold these workshops focusing on active listening tools for supporting mental health, two of the things that are really important. So if you're hosting a group, kind of using this as do-it-yourself, or thinking about it with just you and one other person, highly recommend having at least one other person with you so that you can do the practices. But we highly recommend that we set the stage, set the tone of the group, whatever size group it is, to respect confidentiality and to just hone in on and have reasonable expectations of yourself and each other. So let's see. So anything that is shared in a group setting, please keep that confidential. Especially the practice sessions or breakout sessions, if you're using this to host online or in a shared space. Either way, the practice sessions and discussions really should be kept confidential so that people who are participating are able to feel comfortable and know that if they do share their any insecurities or any specific examples with the group to aid in the discussion and understanding of the skills, then they can do so knowing that information will not carry on outside of that group. So for best outcomes, we do encourage open and honest questions and support from your colleagues that you're working with and doing this with. So it is expected that there will always be a range of pre-existing skills among participants. And so just please remember that no one is expected to be an expert immediately. This is a skill that can be exercised and learned. If you're a biologist like I am, the first time I picked up a pipette, I did not do everything absolutely perfectly. It takes some time. There's some nuance. Some people pick things up quickly, others don't. And then those who have been, trained in this before or have a heavy load of communication with others in the academic space may have developed these skills kind of inherently or innately and have really, really good skills. So it's okay. Don't feel insecure about your own experiences, and please be gentle and encouraging with anyone that you're working with who might seem a little nervous or not quite as skilled starting off. So in addition, Dragonfly Mental Health is not a healthcare provider organization. We are a 501(c)(3) nonprofit based in the US and operating globally. And we only engage in education and not anything clinical. So the purpose of this program is to increase general mental health literacy and knowledge, as well as provide some critical skills that absolutely anyone can and should learn in order to support themselves, their colleagues, their trainees, anyone that they're interacting with in a professional setting that might be struggling. So the information provided today does not qualify as medical advice. It does not substitute for speaking to medical professionals. So I am a biologist myself, as I mentioned. I got my PhD in molecular and cell biology from UC Berkeley. back in 2015, but had been engaged in biochemistry and psychology research prior to that, and then went on to study psychiatric epidemiology at Johns Hopkins for my postdoc. And throughout my research training and career, I ended up advocating a lot for mental health because it affected me, it affected friends of mine, it affected mentors. And so through the years, I ended up creating several peer-led organizations to address mental health issues among academics and researchers at both Johns Hopkins University and at UC Berkeley. And I ultimately ended up connecting with a bunch of absolutely amazing people at an international conference back in 2019. And then we got together and founded a by academics for academics global organization dedicated to cultivating excellent mental health among academics worldwide. So we do a lot of different things. I won't spend too much time doing that, but you can check it out on our website. But our systemic change working group very early on set to identifying like what would be necessary for an ideal setting and situation and culture and climate around mental health in academic spaces, and identified wellness committees being formed, peer networks being created and sustained, having communication between those two kinds of entities, as well as mental health literacy talks and skills workshops like the one that we're presenting right now. In addition to that, and a very critical piece is to address stigma. So people may have a lot of public stigma and be familiar with that, but there's also very deep-seated personal stigma that can come from one's own ideas and experiences, as well as their family or their culture or their country or whatever kind of things have resulted in their own experiences, as well as professional stigma. So we're getting better, but the professional stigma is still the biggest issue that people tend to have when they know that they're having a hard time, but they won't reach out for help or avail themselves of any resources that they do have available even though they know they're struggling, because of the fear of being seen as weak or not as capable in their professional setting, in their professional society. So those are the things that we are addressing, and one of them is workshops. So today, if you're utilizing this online, we recommend having about 2 full hours, but it's basically broken down into tools for supporting student mental health. So this one right now, the orientation we're taking is kind of aiming at faculty and their mentoring relationship with students, with trainees of various sorts. So that's just the tone. We're going to set the tone and set the orientation for that setting. We do also offer this kind of customized more so for training graduate students, for example, who might be teaching or mentoring undergrads, which is a little bit different because the dynamics are different, the time is different, but today, this one is really more focused on speaking to faculty that might be mentoring students that could be struggling with their mental health. We're then going to go over the communication strategies, and then I will present several prompts that could be utilized by yourselves out there in the internet world to press pause after the introduction of that prompt and breakout session and practice session, and then have people, follow the instructions. I'll give the instructions. And then once that is over, once that timing's over, bring people back together and then have a wider discussion if you have more than just the two of you. So then I'll present those, but not include any examples of those. If you want to see some skits of active listening skills, we do have a brief version recording on our website on YouTube channel, so that can be yeah, accessed as well if you want to just kind of have a little bit more of a demonstration and not practice the skills yourself. Then very much right at the end, I'll go over some of the resources that can be made available and touched on, as well as I would encourage any of you that may be using this in a wider setting at your own institution, in your own department, to find your own resources that kind of map onto and your community or your discipline or your local resources on campus. So obviously this particular thing will not be interactive, but the live presentations, either virtually or in person, that you can book through Dragonfly are typically highly interactive. So first, we always like to set the tone and the orientation. So what was even the motivation for focusing on active listening skills for people who are in academia, specifically kind of focusing on faculty? What this is meant to be is a brief mental health introduction, a primer focusing on the student's mental health, not the faculty, and then to review some signs of distress, provide some communication strategies, and then, like I said, we'll finish with a little bit of a resource refresher. Hopefully you are already familiar with resources if you're already motivated to watch this or use this as a tool in your community. This is absolutely not going to be comprehensive training, and it's not training how to be a therapist or a mental health provider in any way, shape, or form. So this is really designed for people, absolutely anyone who is not a mental health expert, not a mental health researcher like I am, to be able to attend or even present to their peers. And everyone can and should learn these skills and be able to have frank but appropriate conversations that are highly supportive of anyone who might be struggling. So why are we focusing on mental health? A major motivation for me personally is that suicides are all too common in academia. I have lost 2 classmates to suicide over the years, and it's really horrible to experience that. And unfortunately, a very large percentage of academics report that they know at least one person who has thought about or died by suicide over the course of their academic career. So student suicide is, actually losing someone in that way is a very motivating force. But in, just mental health struggles in general, there's a negative impact on the education, of individuals, and reduced academic performance among students. And then it also results in student and trainee attrition. Like, they will leave programs, they will leave your school if someone's struggling with their mental health and not able to get the support and the resources that they need to address those. And it can really ultimately damage the success of training programs and reduces the success of the school and the university, as well as their reputation. So doing this is not only the right thing, it is the smart thing to do. It is unfortunately an incredibly pervasive issue. So back in 2017, there was a huge study done by Johns Hopkins of their population, and 44% of their graduate students reported experiencing hopelessness in the previous year. 36% had said depression functionally impaired them in some way, and 57% had experienced overwhelming anxiety at some point in the previous year. 2018, pretty seminal paper at this point in time. Evans et al. Was published that showed very similar things in a much larger study across multiple institutes, both in the US and in Europe. So about 40% scored moderately to severe depression, and that's a present time of when these people were taking the surveys and the screeners. and 41% scored moderate to severe anxiety. There's many other various kinds of investigations into this now, and we do often see that gender, racial, and sexual orientation and gender identity, as well as people who are international students, they do tend to be worse off than their counterparts, which is consistent with general mental health trends. But what's kind of amazing in certain cases is that this is not always true, and the differences tend to be a little smaller among the very high prevalence populations in academia. So, for example, there was a study done at UC across the UC systems that showed that there was no difference in depression rates among men and women in graduate school at the time. This was back in 2014. So kind of interesting because in the general population, there's about a 2-to-1 difference between men and women for depression. So young adults actually have a very high, pretty high risk profile, especially those in graduate school. So graduate school students tend to be in their early 20s, which is the tail end of peak age of onset of new mental health conditions like anxiety and depression and OCD. So high IQ has also been associated with higher rates of self-reported anxiety and depression. And then being far from home and their typical friend group, family group, support group, spiritual group, whatever it is that they have historically had to support them through stressors and through challenges is often gone when someone has picked up and moved to another city, state, or country in order to pursue their graduate career. We all should know in academia that chronic high stress is just part of this environment. Uh, what also can happen is that previously diagnosed or experienced illnesses can become exacerbated because of that high level stress. A lot of graduate students have expressed or experienced financial burden, either by having to pick up and leave the supportive resources that they were coming from. Just moving to grad school can be very expensive. They may have to take out loans, even if it is a graduate program that pays stipends. The stipends have been criticized dramatically over the years now to always be really as low as they can possibly be and not really be supportive of financial security. And then a lot of programs, a lot of students express that one of their major stressors is an uncertain future. They're not sure what they're going to do next. Sleep and diet and lack of exercise are all also typical among a fair number of graduate students who are really inclined to buy into the culture of overwork that really is pervasive in academia. So all of that is to set the tone that everybody has mental health, just like everyone has physical health, and it can be good or it can be bad, and it can be crisis. But I want to take a moment and introduce the mental health spectrum with just a few key points, not go deep dive into it dramatically, but everyone is going to be somewhere along this mental health spectrum at some point. So mental health is where we'd like to be, right? So we're pleasant, we're not struggling, our sleep is good, our feelings about ourselves and our work and our relationships all pretty good. It doesn't mean that you're, smiling like this face is, overjoyed, but at least you're good to go. You handle daily little stressors or surprises with no problems whatsoever. Stress is something that is going to be experienced by absolutely everyone in without fail. So there are some stressors that are actually kind of good stressors. So you're challenging yourself and you're excited about it, and it actually it's tough and it's hard, but it can affect your mental health. But it can actually make you better at something or stronger at something, and that's a good thing. There's a lot of bad stresses out there, and some of them are predictable, like your qualifying exams are coming up, but that is a very known stressor. And then there are also surprising stressors that can kind of come out of nowhere. So you could suddenly have your pet pass away or get very sick, and that can be an unexpected, unplanned stressor. But the thing about being stressed, mentally stressed, is that it by itself is usually pretty easy and quick to get back to that mentally healthy state. Whereas distress is an important aspect of the mental health spectrum to bring your attention to, because it is above and beyond normal stressors that you bounce back from very quickly. And it's more of a longer, heavier, more difficult, mentally distressed state that can look and have some symptoms that you may associate with the next thing on the list is mental illness or mental disease, but doesn't meet that criteria for it. So distress is a state that a lot of academics are in a lot of the time, unfortunately. But what's different about stress and distress is that you may need more time, you may need more effort, or support, or even psychological support, or to get back to that mentally healthy state. Whereas disease is an interesting and important aspect to better understand in general for everyone, because the fact that if you meet criteria for clinical criteria for a mental disease or a mental illness, like major depression or an anxiety condition or post-traumatic stress disorder, if you meet criteria for one of these defined illnesses and ailments, we know what works most of the time. So that is why it's so important to figure out where on the spectrum you are with your friends, your family, your clinicians, for whomever you're comfortable working with or doing it yourself, to figure out where you are on the spectrum, because this is helpful to know if you have a diagnosable disease, because then the tools are readily available to you. And then you can get back to that mentally healthy state even with an illness. So think of asthma. People who haven't had asthma identified or addressed with proper medication and behavioral changes will continue to struggle and have life-threatening attacks periodically, depending on the environments that they're being exposed to. But if they have it identified and addressed and managed for them with their clinicians, they are able to be physically healthy in the same way that almost everybody else is. So this is capable of. So this is one of the elements we should be shifting our thinking, that mental health is just like physical health conditions, in that if we identify it, we can address it. If we address it, we can be healthy, even when we have an illness that we've been diagnosed with. It's a good thing, not a bad thing. Crisis is that far end of the spectrum, and one of the biggest problems, I think, with academia has been historically we've only focused on those two extremes. So just kind of stress reduction things, yoga on the lawn, kind of things and activities, which is great. I'm not knocking it. Or crisis response. Someone is acutely suicidal or experiencing a delusion or hallucinations, and it's dramatically affecting them and they need help immediately. And now, what do you do then and only then? And then we ignore everything in the middle. So we want to stop ignoring everything in the middle, because that's where most of us are. And we are going to introduce a little bit more about mental illnesses to destigmatize talking about and thinking about the diseases themselves, but also distress. So what makes a mental illness a disease, or a mental disease a disease? It's interesting because you actually can kind of lump all of them into a bit of a barrel with three elements. So the symptoms have to be consistent for more than a reasonable time, but it really doesn't have to be constant. It could be more days than not, but you can have good days and still meet criteria and symptom um, uh, check the box for having a mental disease if it's more days than not. And it's usually longer than 2 weeks, but it can last for months. So the criteria for a major depressive episode is only 2 weeks of significant symptoms occurring, that, in addition to these things, they must represent a significant change in the person's normal experience upon onset. So everybody knows the professor who's just really grumpy. Um, and if that's always been their personality, that's their personality. So that's not a change and an increase in irritability. But other folks that develop depression or anxiety or a manic episode associated with bipolar disorder, you may be noticing a significant change in the person's normal experience or behavior. And then finally, this element is very important for mental diseases, is that social, occupational, educational, or other important functioning must be negatively impacted by these changes. So if any of those things are true, then it may rise to and meet criteria for a disease, depending on what's going on for the person. So the thing to know about all mental diseases is that they are real, biologically and environmentally driven illnesses. They can be episodic, they can be chronic, or they can be singular events. People can have a single episode of depression and never again. They can have a single episode of psychosis and never again. But many of them are episodic, where it comes and goes, and they have periods of what they would call normalcy. And there's some people who have developed an illness and it becomes chronic. It's always part of their life in some way, shape, or form. Until it's treated properly. So another thing to know is that no one is immune to developing certain psychiatric illnesses. So developing depression and anxiety really is not off the table for anyone at all. And they are mostly preventable, or at least highly treatable. So what's also really unique about what is unique about mental illnesses in comparison to physical illnesses, if we're going to separate those things, what has been found in epidemiological studies is that it's critical to a mentally healthy climate and culture to have both access to care, but also community support. So it's really important for someone with a mental health condition to have community awareness and support for them to regain or and maintain health after being diagnosed and beginning treatment. Whereas someone, with diabetes, like, could completely privately, with no community support whatsoever, potentially go and get diagnosed and educated about their own condition, and then given the medications that they can then use themselves. But mental health conditions typically need community support as well. So I want to take a moment to point out a few things that we mentioned briefly earlier about kind of minority stress. And so it's very common that the additional stress that people from historically underrepresented groups will experience, that contribute in addition to the severe stresses and issues that everyone is being exposed to. So people that belong to a historically underrepresented group, like women, like Black, Indigenous, or people of color, people who identify as LGBTQ+, first generation scientists, those with disabilities, both visual and or visible and invisible disabilities, and international scientists all experience what are called microaggressions. And these are remarks that may seem harmless, but when they are repeated daily and in all aspects of life, they have a cumulative effect. And they serve as a constant reminder that members of that marginalized group are less than in some way, shape, or form. This is not true, but it is a true feeling and experience that people have. And so these are all, I'm not going to read these out loud, but these are all real minor and major issues that have been experienced by myself or friends and colleagues in academic settings that belong to these different groups that really add to and pile on the stress. And so microaggressions are, they can really make people feel isolated and invalidated. They can also induce anxiety type symptoms like to become hypervigilant. And this can lead to and trigger anxiety and depressive episodes for people that have kind of underlying biology that can get there too. The next two slides were created by our colleague, Dr. Chrissy Stachel, who is a DEI expert and a PhD in chemistry. And she really wanted everyone to know that Kimberly Crenshaw, points out that we tend to talk about race inequality as separate and from inequality based on gender or class or sexuality or immigrant status. But this intersectionality exists. Some people are subject to more than one or all of these things. And so intersectionality in mental health is an important thing to be studying and to look at because what we find is that marginalized populations are more likely to have persistent mental health disorders and tend to be less likely to seek out or receive treatment. But when and so for example, LGBTQ individuals are twice as likely than heterosexual individuals to have a mental health disorder. But when we start intersecting these various identities and experiences, income, by gender, by immigration status, actually has 3 times higher rates of depression. A study that looked at race or socioeconomic status by gender indicated as well that there's more than an additive effect. So these are very serious things that we need to be thinking about, especially when we have a beautifully diverse group of people that are working together on really exciting, wonderful research or studies. So what can you do? Being aware of and questioning your assumptions. And then if you do find that you've ever potentially harmed someone or someone prickles up when you said something that you thought maybe was a compliment, to apologize to those you may have harmed and not become defensive. These are the best pieces of advice from Dr. Stachel for anyone who runs into maybe these issues. So as I mentioned earlier, there's barriers. There's barriers to seeking care even when you know that you have a condition. So we've done some studies and surveys with a number of groups of people now, and the major themes really are centered around stigma. So stigma, fear of professional repercussions, fear of being seen as weak, having a loss of reputation among your peers or your mentor, having a belief that mental illnesses aren't taken seriously, or not as seriously at least as physical illnesses. And there's a lot of self-stigma that manifests as people feeling that they aren't sick enough to seek or deserve care. What has also been identified is a lack of resources, time, but especially money, Fortunately, a lot more US universities, for example, provide free resources, free sessions, but sometimes it's as few as 6 free psychological sessions, or maybe 12. But for some folks, especially if they've let themselves get to or they developed a very serious condition over time, they like 12 is not enough. So and paying for that, as well as finding and carving out the time and not feeling guilty about taking time away from work and studies and teaching, can all contribute to a feeling of lack of resources. Unfortunately, despite there being a lot of resources on many campuses, not knowing where to go is a very, very common reason given to not getting the help you need. And then having heard of previous bad experiences. So we've got a really big problem due to public stigma, actually, where positive experiences are almost never shared. People are more than happy to talk about and celebrate the fact that they have recovered from cancer. But if you got really excellent treatment and were able to address a psychotic disorder that came on during grad school, you're almost never going to hear about it. Whereas there's a lot of people who will go and meet with one counselor, and it wasn't a good fit. There was, it was bad for whatever, who knows reason. And then they're much more likely to share and report the bad experience. And those bad experiences that are being shared more freely and openly than the good experiences are having a negative effect on people. And then finally, one of the issues, especially with the most common mental illness that people are diagnosed with in graduate school, is hopelessness is a symptom of depression. So the illness itself makes you less likely and less able to seek care. So these are all big issues that we're facing, but it paints the scene. And I'm going to shift now because there is, in fact, hope. All of our programs are really meant to be not raise awareness about this bad, terrible thing, and that's it, and leave you there. It is to say, okay, let's shine a light on what's going on. Let's really look at it, and let's see what we can do about it. And so the thing is, we actually know very, very clearly that treating underlying mood disorders prevents suicide. Mood disorders underlie maybe 80 to 90% of all suicides, as estimated by the American Psychiatric Association, and many, many, many decades of studies. And what we also find, though, is that for suicide specifically, if that's one of the things that we want to prevent, immediate suicide prevention does also include removing lethal means and avoiding substance use. So those are both very important in the moment, immediate things. But ultimately, the biggest thing that will help prevent suicides is treating the underlying mood disorder that someone may be struggling with that is causing suicidal thoughts and ideation. So a lot of these illnesses, almost all of them, are highly treatable. About 80% of major depressive episodes are estimated to respond to standard treatment. There are some folks that will develop more what is termed a treatment-resistant depression, but there are many other modes and approaches to address it if that happens to affect you or someone you know. So the first time is usually the charm, but also there are many variations and options available nowadays. And awareness and early identification are actually very, very key to successful treatment engagement. So the longer you wait, the more complicated issues can get. And then, so earlier identification, earlier intervention means a shorter time period between engaging in care and being back in that mentally healthy state. What we also find, and it just bears repeating, is that community support and encouragement is hugely impactful and improves care-seeking behavior and sustained treatment and ultimately recovery and all outcomes for people. So what's also amazing and very, very relevant to the faculty and postdocs who will become faculty and or managers, and even the students who will ultimately get there, but are even today potentially teaching or mentoring undergrads, mentors make a difference. Graduate students who felt their advisors provided mentorship, support, and valued them were less likely to suffer from anxiety and depression. So this is from that 2018 pretty seminal Nature Biotechnology study by Evans et al. And they found that if they agreed with these statements, that their mentorship was really, really good, they were dramatically less likely to experience currently have anxiety or severe depression symptoms. So what can you do and look for? So the mental illnesses that are most common are depression and anxiety. One of the most disturbing ones to experience and observe are ones that include psychotic features. We don't have time to go through every single one individually, so I'm just going to kind of chunk everything together. But if you are concerned about someone or seeing any of these things, emotions, behaviors, and then thoughts and writing and speech can all be ways that you can identify or see that someone might be experiencing those changes and those symptoms that may indicate you do not need to diagnose them, but to know that something's up and you should probably click into active listening mode. So if you see that someone is now becoming depressed or feeling extreme feelings of euphoria that seem to be lasting a little too long, depending on the context, agitated or irritable mood are very common with depression and with mania. Feelings of guilt, hopelessness, or worthlessness are very common in depression as well as anxiety states. Feelings of worry, panic, fear, decreased interest or pleasure in activities that they used to enjoy are also emotions or changes that you can kind of look for. You might also see some behavior changes in people that you're working with or mentoring. So that could be weight changes over a relatively short period of time, gaining quite a bit of weight or losing quite a bit of weight. During qualifying exams at Berkeley, I very distinctly remembering there being about a 50-50 split of my cohort. Change in amount and quality of sleep, isolation or withdrawal from the community, deterioration in appearance and or hygiene, anxiety symptoms, which can manifest in kind of the body. So this is behavior and body. So heart racing or experiencing more headaches or hyperventilation. Gastrointestinal problems are quite common with many mental illnesses that manifest through changes in appetite and abdominal pain. You can also feel heaviness, somatic heaviness in your body. So, or pain or loss of energy or easily feeling fatigued. Behaviors that may also change may be an increase in substance use, either increased frequency, amounts, or kind of using them in more inappropriate spaces or times, including alcohol, cannabis, or anything illicit. And then you might also notice cuts or bruises or burns on someone that never used to be there. And these are all things you can kind of put in the back of your head as potential warning signs. Again, do not diagnose. We are not trying to turn you into psychiatrists or diagnosticians. So that's part of the reason why we actually don't break it down by disease in this particular orientation. So the other thing with mental illnesses that can, especially for academics and students, be particularly distressing is that they will change your thoughts. So you can have slowness of thought or speech, paranoia or obsessive thoughts, racing worried thoughts. Thoughts can become disorganized, or someone might be speaking, but it's kind of confusing. They're hard to follow now. Poor contact with reality is an important sign in the thoughts, writing, and speech. And you might see a loss of impulse control. So maybe some inappropriate, bizarre, or odd comments are starting to come through. Or thoughts or statements about harming or killing oneself is a very, very, very serious red flag that really needs to be taken seriously and not avoided. So, and then try to help and intervene as quickly and as compassionately as you can. And I'll have a recommendation at the very end for actually training in specifically responding to potential suicidal thoughts and actions. There's a fabulous training called Question, Persuade, Refer for that. But other students or colleagues expressing concerns about someone can also be something that you kind of are picking up on in the academic setting. So what can you actually do? If you are a faculty member, the keys to wellness, again, are awareness. So you're already learning a ton of things and clearly keyed in and raising your awareness here and probably elsewhere. Early identification. So not ignoring things until they get absolutely huge and unavoidable. Early identification, and then again, community support. Normalizing talking about it, normalizing checking in on each other, and normalizing taking time to take care of yourself is all, and normalizing the fact that a lot of people are experiencing these things at some point during their career and education. So a couple considerations to really encourage all of those three things is that unfortunately the average person who develops depression but does not seek help right away will wait 6 to 8 years on average before they do engage with treatment. And what has been found is that this, with mental health, it really is dramatic when other people in the community, especially mentors, model self-care, model engaging in care early. So the take-home messages from the initial orientation here is mental illnesses are real biologically based diseases that can affect absolutely anyone. Graduate students are at particularly high risk due to age and high stress. Stigma and not feeling supported and seeking care are two very major barriers to getting help. Most mental illnesses are highly treatable and should be identified and is addressed as early as possible. And then finally, just to say it again, and that's why you're here, community awareness and support is essential to healthy, successful scientific training and research. So if you are watching this and want to take a 2-minute break, please press pause and go ahead and do that. And I will move on as soon as you unpause it. So now we're going to get into the actual communication strategies. It doesn't take that long to go through them, but we're going to explain a few active listening skills and then a few examples, and then go into the opportunity for you to, on your own, take some prompts or modify the prompts and then do some practice with someone or get people that you're with to pair up so that they can do the practices. So we want to set expectations first and foremost, and it's really important for you to set expectations for yourself. And one of those is setting boundaries. So the second is respecting and protecting privacy of the individual. And then the third is communicating with compassion. So you do need to know your own boundaries. So you are a potential resource. You can provide them information. You are a potential helping hand. You could provide actual support or encouragement if that feels right and appropriate to you. You can be a sounding board. So actively listening, using the skills we're going to talk about in just a minute, and providing advice when asked for. And then referral source. You can recognize the need for additional assistance and direct them to appropriate sources, not forcing them, but encouraging. You are not, and they do not want you to be their therapist, a parent, a doctor. I mean, you're probably a doctor with a PhD, but when you're in a mentorship relationship, you do not want to be in that role. And you're not an emergency or a health provider either. So be clear about your boundaries and where you're at, and be able to then use that clarity to set clear boundaries with the person that you're talking to. So you can express boundaries as soon as feels appropriate. So if it really starts looking clear that someone is in mental distress of some sort, say, I am not a trained mental health professional, but I want to make sure you get the help that you need. You could also, but you do also need to be able to indicate any legal limits to confidentiality, depending on what someone might be sharing with you. So that depends on the role you're in, the state you're in, the country you're in. So I won't go into what those are, but if you don't know what the legal limits are as a mandatory reporter in the US or something else in Germany, I don't know what those are. I can't explain them all right here, but if you don't know, you should know what your legal responsibilities are when someone reveals something that they're opening up to you about that's relevant to your professional interactions. So the most important thing, though, is to respect the person's privacy. So do not share names or identifying details with anyone without explicit permission unless you are required to do so by law. One of the things you might share names or some identifiers with would be if you're having a confidential conversation with someone in psychological services in order to get advice about what you should be doing and saying, and they're determining whether or not they will then take that information elsewhere. But in general, the golden rule is respect the person's privacy completely. Active listening skills. So this is how you compassionately communicate. You tune out everything else and focus on the person who is talking. You try to understand what they are saying, both content and what they are feeling, the affect that they're conveying it with. And you put your understanding of the message into your own words and then feed it back to them for verification. The fourth is deliver a message of support. And critically, it's not an evaluation. It's not an opinion. It's not a story about you or what you went through when you were a graduate student. It is not advice. So that is active listening. The four pieces that we're going to introduce and then practice in the practice sessions are questioning, paraphrasing, reflecting, and summarizing. So the first skill of active listening is questioning. So close-ended questions leads to specific and short answers. So are you missing your family? Yes or no. Are you feeling sad? Yes or no. When did you start feeling this way? About 2 weeks ago. Did you talk to your advisor? Maybe you're talking to someone who's GSIing for you or graduate student instructor. No, I didn't. Those are very close-ended questions that will not lead to elaboration in most cases, whereas open-ended questions encourage them to go ahead and keep going. So what's going well for you? What are you struggling with? What would you like to talk about? What options have you considered for dealing with this? These are all really beautiful, open-ended conversation starters that will allow someone that you are now concerned about to be able to elaborate and fill in a little bit more information that can be useful to figure out where you're at and whether or not what kind of role you're going to play. So keys to success are to be careful with why questions. So you'll notice that on the previous page, every single one of those questions started with the word what. What questions are great? Why questions can really come off as accusatory and may make the person shut down and feel like they have to defend their actions or their thoughts. Another really amazing piece about questioning that can feel very hard for people at first is patience. So silence is actually often a very useful encouragement and allows the person to think, to talk, to explore more than if you fill the silence or start making suggestions right off the bat. And in addition to that, minimal encouragement helps move the conversation along as well. Simple nonverbal cues like head nodding or smiling, as well as verbal, go on. Cues can be all they need to open up and share with you relevant and appropriate information. So paraphrase is the next one. So it's when you state in your own words what their verbal message means to you. So you want to keep your focus on the speaker. Don't start telling them a story about how you relate to what they just said. Let them know you're trying to understand their message is what this does. Paraphrasing is very good at indicating that you're listening and you're trying. And it also encourages them to keep talking. And it helps create much more clear communication and avoid misunderstanding, because if what you restate in your own words is not what they meant or tried to say, then they can correct you and you can not go down the wrong path. So the keys to success for paraphrasing are that you clearly capture just the essence of what the person has said. It conveys the same meaning, but does use different words. Just literally parroting back to them the exact words that they just said is not paraphrasing and feels a little weird for both of you. It's great and wonderful to just be very clear, brief, and concise. So even if they were talking for 2 or 3 minutes and then you paraphrase back in a very short sentence, that's totally fine. Very good. And it's typically presented tentatively so that the person has a sense that you would like to understand. You're not just trying to tell them what you think they said. And that's it. Having a tentative tone in your paraphrase will encourage more communication and back and forth. So maybe a speaker says, students sitting there and they say, I've just been feeling so tired and unmotivated to do my class prep. I don't know what's wrong with me. And the listener, the faculty member, can paraphrase back. It sounds like you've been having a hard time and are confused about what's going on with you. Is that right? So the next element of active listening is reflecting. So you can feed back the speaker's nonverbal as well as verbal message as well. So you focus a little bit more on the emotional content of the message as opposed to what the words were specifically. So this does require you to really have your full focus on the person and pay attention to nonverbal cues like tone, facial expression, body language, and posture. So maybe an example would be someone says, I can't believe that presentation went so poorly. I worked so hard on it and I was fully prepared until I stood up at the podium. And the listener may say, it sounds like you're really frustrated. And notice how in the reflection example, they don't even mention any of the circumstance or the details of what the person said, but it's really reflecting back the essence, the nonverbal piece that you picked up from them. So last one is summarizing. So once you've heard a fair amount about information, fair amount of information from this person, concisely restating the points that seemed pretty major to you, and then verify your understanding of the situation. Again, you are not at this point giving recommendations or advice or stories or anything else. You are summarizing, is still in this very active tone of, so it sounds like the loss of your father has really affected you, and now you're having trouble on your work in lab. But what you're telling me is that you don't feel like you have enough time to seek counseling and are worried what others might think of you if you do. Do I have that right? So all of this gets you to a place where you can, you have trust, you have much more information than at the beginning of this, and you are massively more capable of taking the next step to actually help them without overstepping your boundaries. So listen without judgment and clearly express your compassion throughout, but certainly at the end. So a phrase like, it seems like you've been struggling lately. I'd really like to support you. Can you help me understand what you're struggling with? Is something that might compassionately get the conversation started at the beginning, or if it really doesn't seem like you're able to pull it out of them. You can also say kind of throughout, it's really common to struggle in programs like this. I'd like to help you get the care you need to succeed. And then another beautiful phrase to use is, I'm not judging you, but I am concerned. You seem to be having a hard time. So at this point, you'll want to revisit your role and identify, you've got a clarified concern. You have to determine what role you're going to be most helpful to that person with. So your role options, again, are to be a resource, to provide information, be a helping hand. You can be a sounding board or a referral source. And that is all. So we're going to take another little break. So go ahead and press pause, get up, walk around, stretch, let all that information kind of percolate. And then we have underneath this video in the description a link to free resources to just kind of keep handy, which has active listening skills and the descriptions of those different things we just covered. But as soon as you are finished with your break, come back, press play again, and we'll jump into the scenarios and role playing. So for the scenarios and role playing, the instructions are you're going to pair up. Each person will take turns in each role. So it's important to practice both aspects as the listener and as the pretend student or trainee who's struggling. The rounds we typically recommend are 8 minutes, kind of 4 minutes for each person to be in each role. But if you're doing this on your own, you can take as much or as little time as you so choose. But usually if there's a facilitator, kind of keeping time, keeping track, it's good to announce halfway through the round to go ahead and switch. And then it's really good to take a minute or two after the second round, the second half of the round, and have the two people pair up that are paired share some feedback with your partner on what they did well, what might be improved, or any constructive reactions you'd like to share with them. The speakers will play the student role and will respond to a prompt. The listeners will be, your role, whatever your role would be, if you're a faculty or a mentor or program coordinator, whatever have you, and use questioning, paraphrasing, and reflecting skills to try to help the speaker respond to the prompt. So after each round, we encourage that you discuss briefly as a group, if you have a group, and we'll just take it from there. I'll introduce some of the prompts, and then you go ahead and just press pause and press play again when you're ready. After that, if you're utilizing this in kind of live action and not just as an informational video. So scenarios and role playing. The ones that I'm going to have here are a little vague, but some of them do tend to be more specific for maybe scientists or research kind of graduate programs. So if you'd like to look at these and rewrite them for your own demographic or kind of program or discipline, highly encourage that. Please do. So scenario one, round one, is going to be the speaker will play a student whose project or research or maybe their academic performance is slipping due to some personal challenge. We're vague here, so whoever is playing the student, go ahead and come up with something specific that you're going to be that you know what it is, and the listener has to use those skills to draw it out of you. Um, Listener, use those active listening skills to better understand what they're saying and provide appropriate support. So these are short sessions typically, so don't worry about getting to the end and having resolved everything in 4 minutes, but just test it out and see how it goes. So I hope that was interesting. Feel free to have open discussion for a while and press pause again before moving on to the next scenario. So the next scenario we have for another role play is again, pair up, same thing. For half the time, have that one person be the speaker or student, one person be the faculty or listener, and then you'll switch halfway through and then give each other feedback. So the speaker in this one will role play a student who is concerned about more interpersonal issues in their lab, or maybe finding a job after graduation. Either way, they report feeling overwhelmed and are nervous about what to do or how to handle the situation. So this makes it a little harder for the listener to stay a listener, but use those active listening skills to better understand what they're saying and provide appropriate support. So again, hopefully this was a teensy bit easier, but also a little more challenging as things ramp up. Feel free to discuss as a group if you haven't already. All right, so scenario and round 3. For this one, let's have the speaker role play a student who is planning to attend their first conference. They are deeply insecure about how to network. This is something that really is present in this moment in time because COVID affected so many trainees early on. And so there's a fair number of people who are, only going for the first time at the end of their PhD, and they're really not sure how to network very well. So this might be normal nerves. It might be something we are calling imposter phenomenon these days, or could be anxiety. So it's up to the speaker to kind of decide where you are on that spectrum, or if you even know, depending on what information you're going to be giving to the listener. For the listener, again, use those active listening skills to better understand what seems to be underlying this distress and kind of how severe it is, and decide what role you're going to kind of be willing to play. All right, so if you are still here and you are engaged and want to keep going, you can. In the Dragonfly 2-hour workshops, we usually don't get through all 4 of these scenarios, but if there's a really engaged group or there's not a set end time, we can go into this level. Again, also pick and choose. This is a free resource available to you and your community to Use appropriately to improve your active listening skills and support for others, especially those in a mentee role. So round 4, we're going to be explicit about this, that the speaker, the person is going to role play a student who is struggling due to either an exacerbation or maybe the onset of some mental health condition. So, try to draw compassionately from experience of yourself or someone or don't play it up. Don't be hammy. Try to be very subtle and compassionate in this role play. But it some kind of mental health condition that you have enough familiarity with to role play respectfully and appropriately and with authenticity in some way, shape, or form. For the listener, try to use those active listening skills again to better understand kind of the severity of the situation and use compassionate methods to refer the student to appropriate options for getting support. Go ahead. And if you haven't discussed as a group again, please go ahead and do so now. And then we'll move on to finally a few final points and pointers. So if someone is resistant to help when you are trying to support it or recommend it or refer them, if it's a non-emergency situation, if someone is not actively suicidal and they don't want help, remain patient, friendly, and open. Encourage them to speak with someone they trust. They don't have to speak to you, but you can let them know that when they are ready, or if they do want to come back and talk to you about it and discuss more, you're open to it, or there are options for support you'd be more than happy to connect them with. Offer to help in the future if you're willing to do so, but under no circumstances should you be threatening anyone with hospitalization or treatment, or like leaving the program or kicking them out, or don't try to persuade with paternalistic, well, if you don't do this now, you might end up dropping out, or any of that. So just no threats, no threats. That is almost without fail a terrible approach. So that is what we have to say about non-emergency. We will suggest very strongly that when you are interacting with someone, it's important to think about whether or not it's an emergency. So we'll also talk a little bit more about the prevention side of things real quick, and then any on-campus resources you already know about. So if it is an emergency situation, the times to act immediately are when a student makes suicidal statements, when there's a threat directed at others or maybe at property, if they are unresponsive or disconnected from reality, or if the situation feels threatening or dangerous, and certainly if they are incoherent or passed out. And in all of those situations, you want to stay with the person, call your local emergency number. If you can, and they're willing to, walk them to the emergency department or the psychological services on campus if it's open hours. You can contact local student well-being office for consultation, or call security to help aid with emergency services. Most emergency situations most situations are not emergencies, so that's good. But if the situation is suicide, it's important to share your concern And it is absolutely okay to ask very bluntly, but compassionately, are you having thoughts of suicide? How are you thinking of harming yourself? Do you have a plan? Asking those questions is something that a lot of people struggle with, and are worried about that maybe triggering someone to be more likely to commit suicide or die by suicide, and that is not the case. The science and the research has been done that shows that asking if someone is that you are concerned about is having suicidal thoughts or thoughts of dying or harming themselves is actually a prevention. It reduces the likelihood that that person will die by suicide. So do not leave an actively suicidal person alone, especially if they've very clearly expressed they have a desire or an intent to die. But always involve them in the decision making about getting help to the best of your ability. So the majority of the time, we really get to be operating from a place of prevention. So the best thing you can do for students is to encourage and help make space and time for them to engage in their own self-care, whatever works for them, whatever helps them maintain or recover their mental health when they are having an issue. So encourage taking a mental health day, encourage building an exercise routine, getting out in nature, engaging in whatever works for them depending on what's going on, massage and acupuncture, light therapy. If somebody mentions this to you or kind of you overhear it, making fun of these things is something that can stigmatize this, and this might be something that really works for them and helps them. So that is a good thing. Meditation is something that a lot of people do, but many people don't, and some people express strong opinions about them. It's good not to say negative things about activities that other people enjoy and find helpful. Eating healthy meals is always a good thing. Keeping in touch with family and friends, making sure that that is prioritized and encouraged. Picking up a new skill outside of the lab or the training program they're in. In grad school, I learned to play the mandolin, and that was amazing. I had other friends who engaged in sports and art and volunteering and gardening. All of these things are really beneficial for maintaining and preventing maintaining your mental health and preventing exacerbations. And then to model these behaviors in yourself is a very, very strong and encouraging thing to do. And one of the things that, especially if, and I think it isn't discussed enough, is that when you are supporting someone, especially a trainee or a mentee that is struggling, if you're supporting a family member, if you're supporting a spouse or a child, like this is hard for you, the supporter, as well. So if you don't know your own local resources, seek them out and share them with others, but also avail yourself of them. Know the numbers and location of the student support centers so that you can very quickly and easily provide resources. And student support centers will often help and provide confidential consultations for concerned supervisors. And so they can help you with some coaching and options and even language to use to address a wide variety of issues. So be sure to seek support for yourself if you, in fact, need it. So we have workshop reflections, taking action, what can I do, and a pocket guide of what to say, all available in the notes underneath the video on this YouTube. So please, if you are willing and able, take 1 or 2 minutes, that's it, to complete the survey. There's a tiny URL as well as a QR code that will take you to a super, super brief survey that will allow us at Dragonfly to continue to develop and improve these kinds of presentations for anyone in academia worldwide. So thank you all so much for your time, and we're so glad that you are interested in improving your skill set and taking care of your community.